Thank you, everyone, for joining the webinar. My name is Ishai Attar, and I'm the founder and CTO of BioChange. And BioChange, our product, the Regam Vet and the Vet Form. So I'll tell you the broader story of what we are and what we are developing. We are aiming in solving the problem of tissue regeneration. And what is tissue regeneration? Is the self-assembly of complex organs, not just repair of tissue, but actually self-assembly of the complex anatomical and functional structures. And this is what we want to achieve, and this is highly needed after damages of disease, inflammation, injury, or aging. And unfortunately, our natural ability, also that of our pets, any mammals, our natural ability to regenerate is quite limited, and everything else that exists today in the hand of a medical professional is lacking, and it fails to restore the full tissue structures and function, and can provide maybe only minor repairs. But we want to do much more. We want to regenerate complete organs, and the reason we think we can do it is because the initial self-assembly of our body happened when we were embryos. During that organogenesis phase, the initial, if it's humans, the initial 5 to 6 weeks, a ball of cells named the blastocyst evolved and grew rapidly, self-assembling to new organs, to a full organism within such a short time. This is what we want. This is what we want to mimic. This is what we want to do when we are adults, right? So there are very few but really interesting cases even in vertebrates, like the axolotl is probably the super regenerator of vertebrates, because they can grow a full limb within 3 to 6 weeks. If a limb is amputated, and it happens a lot because they are highly carnivorous. They eat each other. And let's see this quick animation. So if a limb is amputated, what we see in the case of the axolotl is closure of the wound and biological reset. So within the next few weeks, we will see recruitment of non-differentiated progenitor cells to the region of injury, and they will reorganize, and a limb bud is going to grow out of the wounded area, and every cell just knows where to go and what to become, whether it's bone, muscle, neurons, everything just happens by itself. So it's a smart material that is capable of self-assembling. I'll give you another really interesting case from nature, and this more basic but really phenomenal organism, the planarian flatworm, can regenerate itself, and even up to 279 times if it cut to pieces. So if we cut it to 3 pieces, we will get 3 planaria. If we cut 278 pieces, we will get 278 small planarias growing into becoming replicates of the original planaria. And they do it. They have the most extreme regenerative capability, and it's all about morpho memory, or navigating in this morphogeneric space, and recreating that anatomy. So the information has to be there in each and every one of those pieces, right? And somehow the cells, they synchronize, they know how to evolve, and more fascinating is that they know when to stop growing the hand of the axolotl, or the head or the tail here. And unfortunately, in humans and pets, we just cannot do it. So what is the difference between those cases, the embryonic phase, and those cases where we get animals that can do the full regeneration? and other animals cannot do the full regeneration. We get a scar. So we understood that this is a problem of cellular communication or transfer of information. Okay. When you don't get synchronized growth, you get a scar and you cannot regenerate organs. But when the synchronization is optimal, anything can be regrown. The information about the morphology is inside every cell. All we need to do is to get them to talk to each other, to transfer information, just in the same way that it happened during that embryonic phase. What we see here in this video, time-lapse video, is the research model for that developmental biologists use and research with. It's a zebrafish, and that everything, the growth, the emergence of the organism and all the organs already there within 1,020 minutes. It's that fast. So that enable scientists to really research what's going on during that embryonic phase in the zebrafish. And there are three channels of transfer of information that were uncovered by scientists, not by us, but other scientists do a lot of research about this. It's the biochemical transfer of information, which has been known for tens of years and researched a lot. The bioelectrical transfer of information, which is not exclusive for neurons. Bioelectrical information is also conducted between any kind of cells. And then there's also the biomechanical transfer of information. And it turns out that the cells communicate with each other by vibrations. And this is something that in biochange, we focus on providing the cells. We are providing the biomechanical structures that can reinstate that way of communication by vibration. What we and others discovered is that the extracellular scaffold is very different between that embryonic organogenesis phase. It actually is a foam. And then over time, when tissues mature, it turns into the fibers that you all know, extracellular matrix collagen fibers, right? So the fibers cannot conduct the same bandwidth of information transfer or the same efficiency of information synchronization that the foam can do. And that's why when everyone else in our field of biomaterials and tissue scaffold tries to mimic the natural scaffold, they try to mimic those fibers. We are trying to mimic that embryonic foam structure, which is different. And why is foam so important? Because I've mentioned the vibrations. So it turns out that foam is a very efficient medium for conducting vibrations. And a research that was conducted by researchers named Ogel Campas from University of Dresden uncovered the way cells communicate through those vibrations. He uncovered actually the existence of disordered, three-dimensional disordered forms that the cells use as a communication device. And you can see it actually in real imaging in the video that you see here above. You see forms communicating through, let me run it again because it's really interesting, communicating through vibrations of that extracellular foam. That's how they know where to go, what to do, and where to elongate, when to stop. So in biochange, we mimic that embryonic foam, and we've evolved it into a scaffold structure that has a micro bubbles. It's actually a microfoam, has very unique biomechanical properties. And I can show you quickly, it comes in various forms. It can come as an injectable. That's what we call the vet foam product. That's mainly used for urology right now to treat urinary incontinence and bog urethra. So that cross-linking takes place. We're using enzymatic cross-linking to stabilize the foam, and then it becomes a solid unit of foam that can be injected or can be implanted in case of the dental care. We've done a substantial amount of preclinical experiments, including skin regen. We've shown that we can regenerate skin, we can regenerate the bone. And we've developed this into the Regum Vet product for treating dental problems. This comes in two different shapes, three-dimensional shapes, and can be implanted in anywhere that's needed to regenerate. And there is a study that was published in 2022 in Frontiers that measured the effect of regum on regenerating the gum and the bone. And the effects are substantial, and they are statistically significant. And since then, we've done more and more. There's more and more case studies. There's more than 3,000, 35,000 units already deployed. We get a lot of data back from physicians all over the world, and we see amazing results. And we also have more studies in the making. You can see here, for instance, on the left, regeneration of the bone line. Okay, this is an F3 furcation. Those teeth should have been extracted, but we were able to save the teeth. And in another case, we were able to regenerate bone and strengthen the jaw structure. And there are more cases that will be covered in the next presentation, including fracture repairs and more. I want to just mention that while all other bone grafts need to be used with a membrane, a GTR membrane, guided tissue regeneration membranes. Why is it needed? Because the epithelia, it grows, the soft tissue grows 10 times faster than bone. And even if you put a bone graft there, it's going to disrupt the bone regeneration if a membrane is not used. The membrane is used to prevent that ingrowth of soft tissue. So I can tell you that when we use the regum in our studies, we did not use any membrane. We don't need a GTR membrane, because once the tissues can communicate and synchronize growth, they do not compete anymore. And that's the evidence is in the data that is published. So with this, I would like to continue to the presentation.
Thank you, Ishai. Heidi, we'll be happy to hear you now.
Hello there. Well, let me go ahead and share my presentation. It's a little bit more basic, but that's okay. That's okay. So, hello, my name is Heidi Lobprise. I am speaking to you. It may be afternoon or evening for some of you. It's morning for me in Texas, but that's okay because some teeth are worth saving. We're going to talk about some practical periodontal therapy and take some of this amazing science that we just heard about and see how we can apply it in everyday practice. So, Ishay was talking about the scaffold for treating advanced periodontitis in dogs and cats, because we know that the prevalence, the incidence of periodontal disease is quite high in both cats and dogs. And the thing of it is a progressive disease. If we don't do something about it, then we can lose bone, we can lose gum tissue, and end up losing teeth as well. So when we look at appropriate periodontal therapy using the Regum Vet, it can help preserve the teeth. And we're going to talk about when we've always thought that extraction was necessary, the only option. What are our options? So as we look at the periodontitis that takes away the bone, attachment loss, tooth mobility, the other thing about dental disease, periodontal disease, the chronic inflammation can impact the rest of the body. And I was listening quite intently to the aging process, because that's kind of my category, and chronic inflammation and the inability to regenerate. Our reserves are less. So we definitely want to keep all of our tissues as healthy as possible. So the Regum Vet itself helps fill the defect, support the defect, providing that foam, that framework for tissue repairs. The cells repair the area, the defect itself. The scaffold is resorbed over time, and the tissue replaces this area. It's a biodegradable scaffold, foamed cross-linked gelatin, and once it's reconstituted, it regains its elastic properties. It's a little bit stiff when it's dry in the cone and the square, but then we do a brief reconstitution with fluid, and then we place it in the defect. We look at restoring the bone, and then also, although bone is a focus, certainly as we look at some of this bone loss, looking at connective tissue and soft tissue healing. So not just getting the scar, but actually getting those tissues back. Certainly, as we look at periodontal defects, deep defects down the root itself, looking at furcation defects, which we're going to talk a little bit more specifically about, and then after extraction, using this to help support the bone regrowth into the area so it's not just soft tissue in there. And then bone fracture, helping to support that osseous healing as well, especially with our mandibular bone. So periodontitis in dogs and cats, it actually doesn't have a whole lot to do about the tooth itself, and it's not about how much tartar or calculus is there. It's about the tissues surrounding the tooth, the supporting tissues, the periodontium. Now, typically, we will focus on the attached gingiva, that band of tissue closest to the crown that is attached directly to the alveolar bone underneath with connective tissue. We also look at the periodontal ligament that attaches the tooth and the cementum on the tooth. So it does have something to do with the tooth, but it reaches across that space and attaches to the alveolar bone. The alveolar bone is one important area that we assess the level of attachment loss. And quite often it's a big factor on whether or not we're going to extract that tooth. When we look at periodontitis, we talk about attachment loss, the loss of these tissues, and the extent of attachment loss, and even the pattern. Very basic on the pathophysiology of periodontal disease, how it happens. When you wake up in the morning, you get this sticky stuff on your tooth surface. That's the soft plaque that adheres to the crown surface. Lots of bacteria in there. When we get minerals from the saliva, this plaque mineralizes, calcifies into calculus, which in of itself, calculus is fairly inert, but it provides a rough surface so more plaque can build up. All right. Now, initially, it's the bacteria and the host reacting against the bacteria that causes inflammation, where we get the attachment tissue loss, the attachment level loss. We might see gum loss. We're going to see bone loss. We're going to see loss of the periodontal ligament and even disease of the cementum on the root. We talk about periodontal pockets, where we measure if there's a defect, if there's a gap in between the tooth and the gum tissue, or the tooth and the bone, because we can have both soft tissue pockets and bony tissue pockets. Sometimes we might not have a pocket, but we have loss of the gum and the bone to where we now have root exposure. And on multi-rooted teeth, we might have furcation exposure in between those roots. So pockets versus recession. Pockets is when that natural, healthy space called the sulcus in between the tooth and the gum line, the area gets diseased. We lose the tissue down the tooth itself. So the depth of that pocket quite often increases. And in fact, since we have these deeper pockets, now with less oxygen tension, we get more pathogenic type bacteria, or black pigmented anaerobic bacteria. So pockets are not good. It's tough to clean those pockets. It's tough to clean them professionally and at home. And we support those pathogenic bacteria. Now, recession, on the other hand, we might have gum loss and bone loss, but that's where we get a root exposure and furcation exposure. And this is an important concept. When we look at our total of attachment loss, we're going to measure the pocket depth, certainly, which is important. But we also have to remember that the loss due to recession, any root exposure we have, amplifies that. So we add together our recession in millimeters and our pockets in millimeters. And we look at what teeth are worth saving. Now, when we do have those multi-rooted teeth and we have recession and pockets. Then the furcation exposure, the space in between those the multiple roots, definitely more challenging to keep clean and puts the tooth at risk.
In fact, with the Paravive, we're
Oops,
looking
my
at
apologies.
how we
Hold
can
on.
maybe do some additional work to help some of these furcation defects. Now, previously, if we had a furcation defect, to begin with, if there was a furcation 2 halfway through, it automatically became a periodontal level 3, which, now smaller premolar, you're going to be extracting it. If it was an FE3 all the way through, it's classified as stage 4 periodontal disease, even if you still have 90% of attachment loss. Think about some of these greyhounds that had that furcation, but are still very solid teeth. That's because it's challenging to clean these areas and challenging to keep clean, but we really have to evaluate how much attachment is left. So as we're looking at these, using the hyaluronic acid gel has been used for looking at some furcation defects, as well as something called regum, using it in furcation defects as well. So we do have some abilities to help heal these tissues a little. When we're looking at attachment loss, it is absolutely essential to take radiographs. We can do probing. We can do many other things to assess how that soft tissue is, but we need to know the health of the bone. How much is still there? How much has been lost? And not just the amount of bone loss, but sometimes even the pattern of bone loss. Do we have horizontal bone loss across several teeth to where the entire alveolar ridge has receded? Do we have vertical bone loss straight down a root and infrabony pocket? These are extremely helpful to assess the level of periodontal disease. Now, always remember, a radiograph is just a two-dimensional image. Sometimes taking additional images can help us out. Many dental diplomates now have cone beam CT with three-dimensional imaging, advanced imaging, and that can really be helpful.
Now, just going briefly through the stages of periodontal disease, as we looked at our stage 1 through 4. Stage 1 may have inflammation, but no attachment loss. We used to call this our only truly reversible stage. When we clean teeth, less inflammation, it goes back to normal. Stage 2 is up to 25% attachment loss. Usually we can get by with doing a good cleaning, maybe some pocket treatment. It's not too bad. We don't want to get any worse from this stage. We want to keep the level of attachment loss steady. Stage 3, we're going to have up to 50% attachment loss. Or we put that stage 2 furcation into this category by definition of the American Veterinary Dental College, which gives me a little bit of pause. Yes, it is more challenging to clean, so that's why we put it in stage 3. Stage 3 teeth, we have to decide, do we clean, do we extract? What can we do to help these teeth? Then we have stage 4, where there's greater than 50% attachment loss. Now, if there's truly greater than 50% attachment loss, it's sometimes very difficult to consider trying to preserve that tooth, treat that tooth, depending on where that attachment loss is. So a lot of times with stage 4 periodontal disease, we're going to be doing extractions. The thing that gets me anxious is when it has stage 3 furcation. By definition, this is a probe going through and through on a tooth with the furcation, multi-rooted tooth. Even if it's barely 5 to 10% attachment loss that allows us specific furcation, stage 3, level 3, it gets put into the stage 4 periodontal disease stage. Now, the reason behind that is that when we have this through and through furcation exposure, it is very challenging to treat. It's challenging to keep debris, plaque, and everything else from really packing into that area. But though many people have interpreted this as meaning stage 3 furcation means automatic extraction, that's just not the case. So when we look at the teeth that have periodontal disease, we look at a couple factors. Do we treat or do we extract? We must be very specific about our case selection for treatment. First off, I do look at the patient's health. I had an Addisonian dog for teeth cleaning yesterday that I thought was going to be teeth cleaning. I even said it out loud. Had a broken upper fourth premolar with exposed pulp. Yes, we could possibly do a root canal on that dog, but longer anesthetic times, yearly exams, everything else, it was best to extract the tooth on that dog. Dogs and cats with cardiac issues, with renal issues, getting rid of that inflammatory impact may be best for that patient. We certainly evaluate the tooth itself. Now, we tend to do a bit more for what we call our strategic teeth, the canine teeth and the carnasal teeth, upper fourth premolars, lower first molars. We also will very closely evaluate adjacent teeth that might be contributing to the disease of that strategic tooth. This is an upper fourth premolar, 108. The tooth behind it, 109. It's a pretty good sized tooth, but we've got deep pockets on that tooth. It's not one of the strategic ones. In fact, it was quite mobile, as is the tooth behind it. At that point, we made the decision to extract those 2 molars to be able to treat and keep the upper fourth premolar healthier. Now, the upper third premolar has pretty extensive bone loss. We can see there's furcation exposure here. What we can't see on the radiograph showed us that almost all the bone was gone on that mesial root, almost all the way down to the apex. A little less strategic tooth, we elected to extract it. We also need to look at what the client is willing to do. If I'm going to put in a lot of great work and some amazing products like Regum in these cases, I want a client who's going to do home care, who's going to come back in 4 to 6 months for an evaluation to be able to see how things are going, potentially retreat, and to be able to follow up. That is an important aspect. So why should we try to save the teeth? As we look at especially that stage 3 periodontal disease, that's where we're making a lot of decisions. Whenever possible, if we can treat that tooth effectively, halt any additional bone loss, stop any ongoing inflammation that can be harmful to the rest of the body, we have a win, especially with smaller dogs. And the thing of it is, the smaller the dog is, the higher the periodontal disease incidence. Also, small dogs live longer. The longer a dog lives, the higher the periodontal disease incidence. So particularly with the lower teeth, the mandibular canines and first molars, pretty large teeth, large roots. If we get bone loss there, we can get enough bone loss that the mandible is compromised and we can have fractured mandibles. So we want to halt the bone loss and maybe even regain tissue, get that bone back. On the maxilla, on the upper, the canine teeth, if we have bone loss on the inside of that upper canine tooth, once it gets past the palatal bone level, the bone in between tooth and nasal cavity is very, very thin. And we don't want that to progress to an opening or communication between the oral cavity and nasal cavity or an oronasal fistula. So I like to consider doing proactive periodontal therapy versus just reactive. And it's not just to save the teeth because the owner wants to save the teeth. We want to reduce the tissue loss, especially bone, and we want to keep these tissues healthy and less inflamed. Now, this means that we start very early in that pet's life doing true preventive dental cleanings. The term prophylaxis means prevention, and that only applies with the stage 1 periodontal disease. But by doing dental cleanings on a regular basis, we can identify and address early levels of attachment loss and disease. That way we can keep these teeth as stable as possible. And then that way we can help facilitate our cleaning professionally and home care as well.
When we look at our goals of periodontal therapy, we certainly want to minimize the attachment loss overall, all these tissues. I do have a special fondness for attached gingiva. Attached gingiva directly adheres to the bone underneath with reed pegs, connective tissue reed pegs. And when we have that healthy attached gingiva on top of healthy bone, that's optimal, all right? But sometimes we don't have it, so we have to evaluate from that. I also want to minimize pocket depth. The reason this is so critical is as we get deeper pockets, we have less oxygen, we have more virulent bacteria, we have more disease. If I have a lower pocket depth, a more shallow pocket depth, I can do better professional cleaning and we can have more effective home care. So that's an important point. And certainly we need to get rid of all the garbage, all the irritants, plaque, calculus, diseased tissues, granulation tissue in there. I've seen kitty litter, grass, even found a human toenail clipping one time, which was really gross. Host modulation therapy, periodontal disease isn't just bacteria attacking the tissues. It's sometimes part of the host immune response that can take out tissues as well. So we have to look.
Now, let's talk about the clinical workflow on using Regum Vet, because we don't just take the product and shove it in that pocket or that furcation, okay? We need a complete periodontal evaluation for each tooth. This is general anesthesia to do a complete dental procedure. We need to be able to take dental radiographs. I know they're not available in every place, but without taking dental radiographs, we're going in there blind, so to speak. We don't know how that bone level is. Sure, we can do the probing of the pockets. We can see if there's recession and root exposure. We can see if there's furcation exposure. But the dental radiographs will really, or advanced imaging, will really help us determine the level of bone loss and the pattern of bone loss. Once we've got that evaluation for each tooth, and sometimes when I hear someone say, oh, that mouth is a stage 2 periodontal disease. Well, no, we do it tooth by tooth, sometimes root by root. So when we look at our evaluation, then we decide, are we going to save it or are we going to extract it? Strategic teeth. We talked about those canine teeth and carnasal teeth. We need to be able to access the area we want to treat. And especially in smaller dogs, sometimes the teeth are so crowded, that can be quite challenging. But typically with our larger teeth, there may be adjacent, less strategic tooth that may need extraction anyway. And this can really help our access to get to that tooth. Then certainly we're going to do a complete scaling. We're going to debride any diseased tissue. We're going to polish surfaces. We're going to irrigate and make sure we don't have any remnants left in there.
So if we do have those moderate pockets up to about 5 millimeters and it's soft tissue, then we can do some non-surgical periodontal therapy. We can do some closed root planing using a small hand curette and really get both the root clean, but also curette out that diseased tissue that's in that pocket. Do you see that blub right there? Now we're going to polish and irrigate, and we may consider using a parasutic therapy. One of the most important hand instruments we can use is a periodontal curette. It has a rounded toe and a rounded back. If we cut it in cross-section, it'd be moon-shaped, half moon-shaped. This is what we can effectively put up subgingivally into the pocket and clean that root plane that root. We do need to keep that edge that contacts the tooth surface sharpened, but we can use this safely in the pockets, whereas a hand scaler with a pointed tip should only be used on the crowns. There are so many curettes out there. If you go online or into a dental catalog, you will be completely confused unless you really love this stuff. There are some curettes that have a little broader curette head to them, working head, some a little bit more narrow, like the two on the left side picture. We have variations in the shaft angle, in the secondary angle bend, even in the rotation and bend of the curette cutting head itself, working head itself. Lots of variations that are made to fit every tooth surface that a hygienist needs to use for your dental cleaning. A curette is a double-ended instrument, and the curette ends are mirror images of each other. So the upper right photo shows two curettes being held with the flip side. They're identical curettes, but the different ends being shown to show how they are mirror images of each other. And there's a Gracie 7-8 pictured below that shows the shaft, the primary angle, the secondary angle, and then the working end itself. Now, in the picture on the right, I've taken the similar side of these two curettes and show you how if you hold it one way, it's open face. You see the face or the flat side of that curette working end. When you rotate it over, you see that you have closed the face. The face is now facing the tooth, and that edge is going to contact the tooth surface. So that's what we need to look at when you talk about closing the face of the instrument. All right, just to see if there's any calculus left in that sulcus. Now, if we do have periodontal pockets, this is how we're going to use that curette.
The curette should be used with the face closed or down and advanced into the periodontal pocket with a pull stroke down, removing any calculus that might be on the surface and up underneath the gum line. This side of the curette can be used on the mesial aspect of the tooth to clean that area. And then you can use the other side of the curette to clean the distal aspect.
Do you see how we flipped over the two sides so we could use it on different surfaces?
Sorry about that. My slide didn't want to advance. So as we look at doing surgical periodontal therapy, once we have deeper pockets than 5 millimeters, or we have infrabony pockets in between teeth, then we need to look at making a gingival flap and releasing that attached gingiva. So in this particular picture up top, my apologies that these overlapped, but the one up top, we have a deep pocket in between the right lower fourth premolar and first molar, 408 and 409. And due to the loss of bone on 408, I've elected to extract it for better access to the strategic lower first molar. In fact, I'm going to be making my incision through the gingiva to do an open gingival flap away from the site of the defect, because when I get ready to suture it, once the fourth premolar extracted, I'm going to have healthier tissue around that lower first molar. This lower picture just shows the blade, talking about how when I cut into the tissue with a bevel to try to remove the diseased tissue that's lining it.
So when we think about regenerative therapy, we're usually thinking about these infrabony or infrabony pockets, that attachment loss that goes straight down a root, and we have vertical bone loss. All right. We actually describe what remains by the walls of the bone that remain around this defect, and that helps us also determine what's appropriate to treat and even what to expect. All right. So just getting a little deep dive here. When we're looking at using bone graft material for a deep infrabony pocket, or even a moderate infrabony pocket, come to think of it, the three-walled pocket is typically the best to work with, because once we've cleaned everything out, we now have three walls made up of bone that will supply osteoblast to help fill in, and then the one pocket of the tooth itself. Now, occasionally, if that pocket extends to the adjacent tooth, we're going to have a two-walled pocket, and we're going to work between these. I'll be honest with you, with most of the teeth we'll be thinking about this type of therapy, we're looking at the lower first molar with the adjacent second molar or fourth premolar, or the lower canine, mandibular canine, with the adjacent incisor. And in most instances, I will be doing selective extraction of the adjacent tooth for better exposure to that tooth I'm trying to save. I'm trying to treat periodontally. Now, in theory, having a cup-like defect gives us the most osteoblasts possible, but it's challenging to clean all around that moat, okay? Sometimes we'll have pockets that extend on the mesial aspect of the tooth, think about the lower first molar, and wind its way a little bit around the lingual aspect, making a C or J-shaped defect. But trying to get the entire moat cleaned up can be a bit of a challenge. So our three-walled pocket with potential adjacent extraction, kind of the one I want to find. So when we look at this bone loss, we're looking at that intrabony pocket. One of the concepts is, yes, if you clean it out really well, it will be a healthier situation. But soft tissue will grow back into that pocket much more quickly than bone or periodontal ligament. So in addition to really cleaning that out well, we talk about using barriers to keep the soft tissue from growing back in. This is what we call a guided tissue regeneration. We're trying to do things to help guide the bone into growing back before the soft tissue does. Now, if the soft tissue grows back in, it may be fairly healthy. We'll call that a long junctional epithelium, but it may continue with a fairly deep pocket, so not as healthy as we'd like. All right? So we're going to look at using implant material, and we've got some various ones that we can use. I know a lot of diplomates aren't real fond of console even for extractions because it's synthetic and it's a bioglass. So you put it in there to act as a scaffold where bone cells will go across. And if you were ever to do a histopath of that lesion, the product would still be there. But for me, doing a bone fill, number one, some of the other products are now more difficult to get and they're definitely more expensive. But on an extraction site, to get bone fill for a stronger area, it's not going to be as strong as full bone, but it's going to be better, even in some minor infrabony pockets. But if I really have a pocket that I need to get great bone health, I'm going to go with more osteoconductive products, such as PerioMix or some of the Synergy products. That's why for other scaffolding, the gelatin-based Regum, which uses a cell foam technology, we primarily have the solid forms available for veterinary dentistry now. I believe PRN is carrying it. And as we look at this, it helps scaffold the bone cells growing across in both infrabony pockets, but we're also looking at it for furcation exposure areas, okay? So as we're looking at that, another scaffolding type will be the hyaluronic acid, a new product. When we're doing full-blown guided tissue regeneration, especially if you're a diplomate or a diplomate with a resident at the college, you're going to be using both that bulk material, such as your PerioMix, but you're also going to need a membrane to really help keep off the soft tissue. So we need to be able to get in there and do precise, complete root planing and cleaning. So that means access. That means doing some type of gingival flap. We need to remove all of the irritants, plaque, calculus, foreign bodies, like I mentioned, inflamed connective tissue, granulation tissue within these infrabony pockets, and even smoothing down irregular bone surfaces, all right? Now, we used to talk about just debriding that root surface, you know. Actually, we want to be a little bit more gentle, just in case there's some periodontal cells still present that might repopulate there. And as I'm beginning, I always start with the end in mind. So I extracted the incisor. So my incision is going to be on the mesial edge of that incisor and no incision that's going to be around the canine tooth. I want to have a complete edge of healthy attached gingiva when I get ready to close that defect. And mandibular first molars are probably some of our best opportunities in our patients. If we have bone loss because the adjacent teeth, we have periodontal disease between these teeth, and we are starting to now get compromise of the bone on this large first molar, I'm going to do something about it if it's a decent patient, okay? So both the mesial aspect, if there's bone loss between it and 08, 408 here, or the distal aspect, which happens frequently with the 410, especially with the 410. That tooth typically has to be extracted so I get good access. Usually with the 08, it's important because those usually are very crowded. Again, I will make my releasing incision far away, or at least away from the lower first molar. So when I get ready to suture it, once I cleaned off all the debris, all the disease tissue on the inside of that flap, I'm going to have healthy attached gingiva sutured around 09. So here's the post-operative where I've extracted 408, 410 was gone. I was able to do open root planing, visualize the root. I want it to be clean. I want no attached gingiva, sorry, my apologies. No granulation tissue in there. I want bone, I want tooth. Then I'll put my bone graft material. If I have a membrane, I'll do that. And then close the gingiva. And 6 months later, while I do have some root exposure, I have much healthier periodontal bone around this tooth. I don't have adjacent teeth that can contribute to its periodontal disease. And if I have that owner that's going to do some home care, we can save this tooth for good.
So here's the visual now of a similar case. And I don't know if you noticed, but those x-rays were from a case back in 2014. So we've been doing some of this work, but it's kind of cool to have new products that give us some excellent tools. So looking at the adjacent tooth step by step, I know I need to be extracting 408. I make my cut mesial to 408. And in fact, I will use my blade just inside this pocket to start to debride that diseased tissue. Once I've got that exposed, I can easily extract 408. If this wasn't so crowded and rotated, I might be able to clean this pocket while preserving 408. It's not as strategic as 409.
Here is one of those situations, very similar, where when I extracted the lower fourth premolar, you can see all the calculus that I couldn't have gotten out without extracting that tooth. We have a moderate infrabony pocket here, but once I clean it out, I can put a little bit of my bone graft material there, even in the alveolus of 08. And now I will clean up that gingiva. I will scrape it, debride it, make sure it's healthy on the internal surface, and suture around the front part of that tooth, the mesial part of the tooth. That will likely cause the gingiva to be a little bit lower on the tooth than it was before. And we're going to have some root exposure, but we're going to have a healthier situation. Especially with crowded and rotated teeth, sometimes we talk about extracting the middle one in crowded rotated teeth and make the other ones healthy. Sometimes the distal root of 07 will be rotated into the mesial furcation of 09. And that might be an area that we can work. But remember, with 3 roots of 08, the 3 roots of 08, if we have furcation involvement, it can be a little bit challenging to get full cleaning in there. So using our products such as hyaluronic. Another area that is frequently treated is the palatal aspect of the maxillary canine. Now, this is doing a crescent incision for access, and it's kind of tough getting these images because there's the palatal artery, so be careful of that. This is where we're going to be working with an infrabony pocket that extends through the depth of the palatal bone, but usually not much further because the bone after that is very, very thin. If you happen to be cleaning here and the nose starts bleeding, and then it probably won't work so good. If it's oronasal fistula, then I'd go ahead and extract. But if you can get it where you still have a little bit of a base of bone at the base of this pocket, and usually it's C or J shaped around the mesial aspect, then you can do a flap, do some thorough cleaning. You can get some bone graft material in there. Make sure that you suture it up nice and snug. Usually by the time you've trimmed away any diseased tissue, you're going to have a good snug suture there. You can also do something we call a sling suture to really make sure it does well. So here's working on the maxillary 304. My apologies, it's 404. And once I do a mesial and distal incision, and I'm not going as far into the palatal artery here, but you can see that gap in between tooth and bone, all right? And if you can clean well and you can see the base of that bone, that it's not going into the nasal cavity, do a good, thorough, but careful cleaning, get your bone graft material in there, and then you can see by doing the suturing mesially and distally, I've got that gingival flap snug, that mucosal flap snug against that tooth. And we can end up keeping these teeth from progressing to oronasal fistulation.
So going back to that last with the upper canine, we would always say if there was always an opening, already an oronasal fistula, any particulate material might just be sneezed out. While I have not had an appropriate case to use it on, using the regum with the square might be the appropriate way to keep material in that site that won't be sneezed out with the next good sneeze. Now we're going to look at some of the case studies that have been that have occurred using regum vet in different areas. And this is with Dr. Anna Nemec from a case study that they did looking at some results in a preclinical study, looking at treatment for softened bone tissue simultaneously. Remember, with all the other products, we were talking about bone regrowth. And in looking at something that can help direct organized tissue repair and regeneration, we can get a much healthier overall effect. So this study looked at split face controlled study, treating deep periodontal pockets with regum versus debridement, good cleaning as a control. And in looking at soft tissue regeneration, pocket depth improvement, we had an extreme improvement of probing depth change. And then in looking at 3 months after looking at the alveolar bone height, again, improvement in that bone. And the radiographs are just so indicative of how well this can happen. The thing of it is, as we look at bone growth, seeing this rapid of a change in this amount of time is absolutely amazing. And in the past, the top radiograph, we would absolutely consider extracting that tooth. Because while I was talking earlier about having defects at the front and the back of this lower first molar, we had less options for looking at the furcation. But now with the regum vet, we have some better opportunities. Here's another one where with those incisor extractions, another place where by extracting the less strategic adjacent tooth, we can make the more strategic canine teeth healthier. Now we can use the regum as an implant placement in the alveolus. And even as we do those extractions of the incisors, we can have healthier areas around that canine tooth. Now, the regum cones, the regum squares don't show up on x-ray, but then once that heals and we can see where the bone regrowth is supported. Here's a case study from Dr. Baram where there was a fracture right at the mesial root of 309. We usually see these type of fractures where there's already been some periodontal bone loss and some decrease, although we have some pretty good bone structure here. But as we look at where that root is, keeping a root that's been damaged, especially its blood supply, in the site of the extraction can end up causing issues. All right. And so this front root was removed, and a root canal type procedure called vitopulpotomy was done to save the back root, the distal root, but only fixing it with a wiring. We still did not have a good union there. It still was unstable. So the site was cleaned, regum vet was placed at the site, and we have mandibular healing of that fracture after not having good healing. So this is an excellent case of showing how regum vet can help support that healing of the tissues. The picture on the right was the one with Dr. Anna showing that furcation exposure. And then we have a case from Dr. Jen Mathis where there was severe osteomyelitis. There was abscessation of this lower first molar and the premolar in front and the molars in back. And this is very damaged bone. This bone is compromised. How this bone did not fracture on its own, I'm not quite sure. But looking at these CT images, 4 months later, after extracting these diseased teeth and using regum, we have got some phenomenal remodeling of this bone. The jaw itself is much healthier, and we've got a site that is visually not inflamed. So an excellent case study there. Here we're looking at a case from Dr. Scott that's looking at, actually on the right side, we have extraction of incisors and a regum was placed. And usually when we see these cases, that bone level stays about the same level, all right? But looking at it on the radiographs on the left side, 12 weeks later, we've got complete bone fill up to the original incisal bone level, which is very good for the support of these lower canine teeth. At times when we have loss of incisors, we just have continued bone loss in that symphysis until the canines were no longer supported. So this is a good way to help support that bone. Here's another case from Dr. Kristen Scott in North Carolina. Large lower canine tooth was extracted, and you can see what a space that happened, what a space that makes. Without providing any type of further treatment, soft tissue can grow down in here, and it can usually stay quite weak. But by using the regum product within this alveolus, we have much more solid bone levels post-extraction and a stronger jaw. On the same case, we have some incisors that were extracted. And here we have on the left, immediately post-operatively, and on the right, where that will usually be a lot less dense, we're having good bone healing for this particular case. Here it's showing with the incisors in before they extracted, and then the healing of that site by using the regum. So by using the regum in practice, there's a couple important aspects of it. We cannot just place the regum if there's a pocket of furcation and expect to be successful. We need to have good equipment. We need to have the right equipment. We have to have the right skills, the right training. We have to be able to treat this periodontally effectively. And it's important to have the right patient and tooth. If we try to do this on every tooth and it's not stable tooth, or we have deeper bone loss than what we anticipated, it's not going to be as successful. Certainly, preparing the site meticulously, making sure we get good cleaning in the area, that we're using our curettes to make sure there's no leftover calculus or debris, and making sure we have a site that has healthy tissue around it, that the tissues can utilize this cell foam matrix, this support to help heal into that area. And then that pet owner commitment for home care. With all these things, I think we can have some excellent results. And we now have options we didn't have before. So we're pretty excited about how this is going to continue to grow. And we'll take it from there.